I would now invite our distinguished speaker, Dr. Jeyakumar Meyappan. Sir, please join us on stage. And now I would request our chairpersons to introduce our speaker.
I welcome Dr. Jeyakumar Meyappan to this holy city of Prayagraj. Dr. Meyappan did his MD from Jipmer, Pondicherry, and his DM in nephrology from SGPGI, Lucknow. He has many papers, more than 25 in various national and international journals, and he has been awarded the Best Nephrologist, Young Nephrologist Award by International Society of Nephrology Frontier in the year 2022. In the year 2021, he was awarded the Best Senior Resident Award at SGPGI Lucknow. And in 2024, he was awarded the Best Research Award at SGPGI Lucknow. Presently, he is working as professor at PGI Lucknow, and he will be speaking on the topic non-diabetic kidney diseases in cases of type 2 diabetes mellitus. Now I ask Dr. Meyappan to please proceed.
Thank you, sir, for the kind introduction. At the outset, I would like to thank the Allahabad Medical Association and Dr. Anurag, sir, for having me here. My topic is on non-diabetic kidney diseases in type 2 diabetes mellitus, how to suspect and treat. So nearly 30 to 40% of diabetics have renal involvement at some point during the course. Proportion of ESRD attributable to diabetes is about 12 to 55%. That means at every alternate patient who is on dialysis is likely to be due to diabetes. And it is rightly said that it is a medical catastrophe of worldwide dimension. But my topic is not diabetic kidney disease. We are going to pick needle from the haystack. We are going to look at what is not diabetic kidney disease. For that, we need to know what is. The natural history of diabetic nephropathy. This is a very important slide to understand that there are 5 stages, as all of us know. The first stage is a stage of hyperfunction and hypertrophy, which is characterized pathologically by glomerular hyperfiltration. And there is actually an increase in GFR, and albumin excretion may be increased, or usually it is normal, and the blood pressure is normal, and it is present at the time of diagnosis. So most of these patients actually don't come to a physician or a nephrologist. Now, next comes the stages which are of importance. This is the silent stage, where the pathology of expanded mesangium starts. The GFR here again is normal, and there is an increase of albumin excretion, what we just begin to see at this point in time. The blood pressure may be normal or slightly increased. This is in the first 5 years of diabetes. And next is the incipient stage, which is very important, or the stage of microalbuminuria, which is where if we miss the bus, we are going to lose the kidney very soon, is when the GFR begins to fall. And the albumin excretion is about 30 to 300 milligram per day, and the blood pressure starts to increase. And this chronology is again very important, is from 6 to 15 years. Then we have the stage of overt diabetic nephropathy, where the patient has edema, has more than 300 milligram per day of albumin excretion, and the GFR comes below the comfortable cutoff of 60 ml per minute. So this is where the patient usually seeks attention, but we need to start acting in stage 2 itself, or even in stage 1. Now, stage 5 is uremia or ESRD, where the patient's GFR is less than 10 ml, and then we start counseling about renal replacement therapy options. Now, coming to approach to a patient with diabetes and renal dysfunction, now we always have to know that what is atypical for these patients. Now, the atypicality can be anywhere. The atypicality can be in the albumin excretion, the atypicality can be in the chronology, the atypicality can be the GFR albuminuria mismatch, the atypicality can be in the course, the duration, the rapidity with which they process. So now we need to look at what are the atypicalities and how do we proceed. Now, where is an evidence of non-diabetic kidney disease? First is the absence of typical chronology that we just saw. The second is the presence of rapidly declining EGFR, or the presence of rapidly increasing urine albumin excretion, presence of active urinary sediment. When we say active urinary sediment, we mean that more than 40% of dysmorphic RBCs, or even a single RBC cast, or even 5 RBCs in a urine sediment. Presence of systemic signs or symptoms suggestive of a non-diabetic kidney disease, or absence of retinopathy in patients with type 1 diabetes, but in type 2 diabetes, this concordance need not be there. So patients with type 2 diabetes and nephropathy having a retinopathy, this concordance is only 40 to 50%. This has been spoken to by my teachers and teachers of teachers this morning. AC inhibitors, era of ARBs, and then flozins, and then now we are using the GLP-1 analogs. But it is important that it is causing an improvement in the cardiometabolic axis, but it is also more importantly changing the way diabetes is presenting to us. And let us see how. Now, with these agents, this is one of our published papers on the spectrum of kidney diseases that have been changing with the usage of these agents. Now, just like the blind man and the elephant theory goes, that how to use these newer agents is still evolving. The learning objectives is we are going to see the atypical form of diabetic kidney disease, which is called as non-albuminuric DKD at first. Second, we look at what is non-diabetic kidney diseases and how to suspect, and a brief mention of the therapeutics. Now, I would like to start and take the talk forward with cases. Now, a 42-year-old gentleman who's 15 years diabetic, 8 years hypertensive, presence with pedal edema for 3 months and decreased appetite. He has proliferative diabetic retinopathy. He has distal symmetric sensory polyneuropathy. His GFR in August 2022 was 45, 2 months later 34, and then 29.2. Now, this is not a normal trend in the eGFR fall. Now, for a diabetic, if they are on these agents, the accepted fall is 2.5 ml per minute per year. In other words, when do we call as a rapid fall? In a patient who is not on any of these renoprotective agents, if the fall in GFR is more than 10 ml per minute per year, then we call it as rapid fall. Or if they are on a RAS inhibitor, then the fall is about 5 ml per minute per year. So these are acceptable cutoffs for diabetics. If the fall is more than this, then we call it as rapid fall. Here the patient has a 16 ml fall. And as we can see here, he had anemia, creatinine was 2.3, proteinuria was 6.6. We go ahead and investigate these patients. We suspect for non-diabetic kidney diseases. We look at, because he has proteinuria and a rapid fall, we send his antipla to our myeloma evaluation, and we look for the USG abdomen, normal size kidneys as we expect in a diabetic. So we go ahead and do his biopsy. Now before that, let us look at how do we approach these patients. First important is duration. This was 15 years. Chronology of albuminuria and hypertension. Here hypertension was diagnosed 7 years after diabetes, which is fitting into the story of DKD. The onset of renal dysfunction and rate of decline is important. Here there was a rapid decline. Now, assessment of end organ damage is again important. The patient had all forms of microvascular complications. The ancillary investigations reveal that the patient has about 6.8 gram proteinuria, which is not very massive. For a case analysis, is this DKD or NDKD? This is where the question comes in. Because he has a rapid fall in eGFR and a disproportionate anemia, we go ahead and do the biopsy. Biopsy is showing all classical features of diabetic kidney disease. The patient has increased mesangial matrix, he has blood vessel hyalinosis, and this was a diabetic kidney disease, just a rapid decliner. Now, as we can see here, this is the electron microscopy findings. This was class 3 diabetic nephropathy. Now, he was managed with anti-diabetic agents, dapagliflozin was added, his ACE-ARBs were optimized, and he was discharged. On follow-up, his renal function has stabilized and he is continuing to be on follow-up. So the learning point is a rapid fall in GFR, though is an indicator of NDKD, can be found in patients who have poorly controlled sugars and blood pressure. Now this brings us to case 2, is a patient who has diabetes for the last 15 years. He has hypertension again, poorly controlled hypertension, sensory neuropathy is there. He again has some anemia, creatinine is 3.6, but he is not having proteinuria. Now here is a patient with some renal dysfunction who does not have proteinuria. Now how do we go about in him? Is because the points that were favoring NDKD here are there is no retinopathy, there is some microscopic hematuria, he is non-edematous and a non-proteinuric renal disease. So these are points that are favoring NDKD. What is favoring DKD is there is long-standing duration and the onset of hypertension is about after diabetes mellitus is fitting into the story and it's about 7 years. Now the differential diagnosis in such a situation is a non-albuminuric DKD or an interstitial nephritis where there is not much proteinuria as we all know. Now this patient was biopsied. This showed normal glomerulus with arteriosclerosis. There was marked interstitial fibrosis. There was moderate tubular atrophy. So this was a case of a diabetic vasculopathy. So this is what we call as non-albuminuric DKD. This is becoming more and more common as patients are being introduced on SGLT2 and ACE inhibitors. So non-proteinuric DKD is not equal to non-diabetic kidney disease. This is just an under-recognized variant of diabetic kidney disease. So any patients who presents with renal dysfunction and does not have much proteinuria, always think about this variant. Now what is the progression of a typical DKD? As we have already seen, they lose about 5 to 10 ml per minute per year. Those who have a atypical presentation, that is non-albuminuric DKD, they progress slower than the routine DKD variant. Now there is a growing phenotype. This is in most of these published studies, it is well accepted that about 40% actually never develop albuminuria and in fact they have diabetic kidney disease. Right, so we find that in our data about 1/3 of all our diabetic patients who have a diabetic kidney disease are of this variant. They are of non-proteinuric or low proteinuric variant. And as I was just mentioning, they have a slower course and they reach ESRD later stages. This is maybe because of recurrent episodes of AKI, maybe even under-recognized UTI is contributing. This is because of the increased usage of SGLT2 and RAS blockers. So this is the pathology. There is disproportionately severe tubular interstitial lesions. And how will the course differ? They tend to be slower, but again, importance is RAS blockade and SGLT2 inhibitors. Though they may not have the benefit that they have in a proteinuric DKD, still we have to put these patients on RAS blockade and SGLT2 inhibitors, being very watchful of a UTI. This brings me to case 3, a diabetic for last 20 years. He is hypertensive. He has bilateral pedal edema. For the last 12 months, his previous creatinine value was 2.1. He has end organ damage in the form of non-proliferative diabetic retinopathy. He comes to us with EC fatigability and oliguria for the last 1 week. So he has some anemia. He has subnephrotic proteinuria that is about 2.1 gram. And there was nothing else that was significant on investigations. Now what is this patient? This is a patient of acute on chronic kidney disease, because as we can see here, 1 year back when he was following up with his physician, his creatinine was 2.1. Suddenly, about say even within the 1 month, his creatinine has jumped up. So this is the renal syndrome, what we call as acute on chronic kidney disease. There is an underlying chronic kidney disease, but there is some acute insult. This has happened here. This is very rapid decline, and this is possibly due to secondary to infection or due to drug-induced interstitial nephritis. Now, as we were said that because there was a rapidly declining EGFR, the patient had some active sediment and presence of systemic signs or symptoms. He was biopsied and biopsy was showing glomeruli were having some increase in mesangial matrix, but what brings us to attention is the tubules is full of interstitial inflammation. There are a lot of lymphocytes that we can find here. Then this patient was reported to us as diabetic nephropathy with acute interstitial nephritis. Now this is where we need to go back to the patient. And when we have taken a detailed probing history, he comes up with his alternate prescription, that is the alternative medicine that he has been taking. Many of these herbal medications are actually being sold in such which mimic our routine tablets, and some of these patients actually take them for years together. Now he was taking this since last 2 weeks in desperation of to control his sugar, And this was the culprit that caused the AKI. All his medications were reviewed and the alternative medications were stopped. Within 1 week, his urine output started improving and the creatinine was settled down to 1.51. Mind you, this is not going to go back to normal because he already had a chronic kidney disease that was underlying. And then every episode of AKI is going to add to the insult. And it is not always the story. If the offending agent is withdrawn, it is not that the GFR is going to come back to normal. We had another patient in whom we went back and asked the history. He was taking fish gallbladder for control of sugars. And in fact, someone outside had made a AV fistula for him, and he was on dialysis for 1 month. And when we asked this history that he's taking fish gallbladder, that was stopped, and he was taken on steroids, and he was discharged with a creatinine of 0.8. So this is where history becomes very important, especially when someone comes with such a history where creatinine has jumped within 1 week to 1 month from 2.1 to 8. Now, this is our experience of about 538 biopsies in diabetics. We find that the most common indication is a combination of either an AKI or AKI on CKD. So, the other indications that we biopsy being rapidly increasing proteinuria, rapid fall in GFR, and active urine sediment. So, these are the common indications, and this is the most common presentation of NDKD at our center. So, the learning point is, especially in diabetics, polypharmacy is very common. It is very important to go through their prescription of both the routine medications as well as ask for alternative medications. And identifying and stopping these drugs may stabilize the renal function. Now, this brings us to the case 4. Again, a hypertensive 60-year-old diabetic since last 4 years. He presents with facial puffiness and ankle swelling. He has grade 2 pedal edema with a BP of 150/100. He does not have diabetic retinopathy. Now, the odd points here are he has a short duration diabetes and he does not have end organ damage. And hypertension is preceding diabetes by about 10 years. So, this patient presented to us with no anemia. He has albumin of 2.9 and a proteinuria of 7 gram per day. So, what are the points in favor, or whenever a patient, this is the classical nephrotic syndrome presentation where they have nephrotic range proteinuria, hypoalbuminemia, and hypercholesterolemia. So, in such a syndrome, what do we suspect? Especially in patients who have diabetes. The most common we suspect again is diabetic kidney disease. But here the patient had a short duration, had onset of hypertension which was much before diabetes, and there was no diabetic retinopathy. Now, when we look at the other common causes, we see that membranous nephropathy, MCD, and FSGS are very common, and that is why he was biopsied. Even before biopsy, we had this very important serum marker which can be game-changing in patients in whom we are actually not able to biopsy. His serum plateau was elevated, not very much, the cutoff is 14, but he has an elevation of about 38. His biopsy was done, it had a typical thick and stiff capillary loop with the silver stain showing focal epimembranous argyrophilic spikes, very classical of membranous nephropathy, and the serum, the biopsy IHC was showing positivity for plateau R, and electron microscopy showing subepithelial electron dense deposit. This is a classical case of membranous nephropathy. But what is the problem here is that diabetic nephropathy and membranous nephropathy can mimic each other because both are proteinuric illnesses. Pathologically, both are characterized by thickening of the basement membrane. But it is very important to differentiate them. And one of the things that is very important, easily available across all centers, is the availability of the newer serological markers, especially serum phospholipase A2R antibody. Now, there is a spectrum newer change of these agents, these antibodies which have come in, which we can investigate and find out if these patients are positive for any of these antibodies. Very important is plateau R, which can be done everywhere. A few of these are done on the kidney biopsy, but whenever we find them positive, they will add to the clue. Now, it's a big therapeutic challenge because membranous nephropathy requires a heavier dose of immunosuppression, and these patients, as we have found in our center, do not go into remission because those who without diabetes, membranous nephropathy has got excellent response, has got 80% remission rate, but in those who have diabetes, it's only a meager 18%. It's also because there is an underlying DKD, and they also have, because of the immunosuppression, high treatment-related morbidity in the form of worsening diabetic control and cytopenias. So in our patient, we did not choose a steroid-based regimen. We chose rituximab, and the patient had, on follow-up of about 6 months, he had a decline of proteinuria to 1.7 gram. So learning point in diabetic patients, again, all proteinuric diseases may not be related to diabetic kidney disease. Whenever there is a rapid onset of proteinuria, as was discussed in the morning, it's not a single snapshot, it's a serial investigation that helps us. Rapid onset of proteinuria, which is doubling, and absence of end organ damage are important clues to identify primary glomerular diseases in those who have proteinuria. Now this brings us to the last case, a diabetic since last 4 years, a 50-year-old, hypertension since last 6 months with a non-healing foot ulcer of 2 months. He comes with facial puffiness and a very important symptom of cola-colored urine since the last 1 month. He has hypertension and is in volume overload. His TLC was elevated. His creatinine was 5.3, which has been increasing within the last 6 months. He had active sediments. Look at his urine RBCs is about 90 to 100. And here he has his serum C3 was low, which was about 35. What is the importance of C3 here? C3 is an important complement protein which gets activated whenever there is infection-related glomerulonephritis. So it is an activation of the alternative complement pathway. So here again lies an important serological marker which is easily available. So whenever a patient with a nephritic spectrum presence in a diabetic, this is a game-changing marker. If you find low C3, he is almost always going to be having IRGN, and this diagnosis is important to make. The syndromic diagnosis was AKD, or we can even call it RPRF. The pathological diagnosis, because we have ongoing infection when we see the patient, or even if we had ongoing infection at this onset of symptoms, this becomes an important criteria to identify IRGN. So this was his histopathology, which was showing lobular accentuation, and as you can see here, there are neutrophilic infiltration, which is very suggestive of infection-related glomerulonephritis. There are also some diabetic changes in the form of mesangial matrix expansion here, but what is predominating is this lobular accentuation and the neutrophilic infiltration. We are able to see the classic subepithelial hump that we see in childhood PAGN as well as in IRGN. So this was the final diagnosis. With the underlying diabetic kidney disease, there was infection-related glomerulonephritis. So source control becomes very important here. The patient had MRSA, appropriate IV antibiotic, good control of sugar and blood pressure is all that was needed, and the patient started having improvement. Now, our experience over 4 years, there is a general this thing now currently with the newer RCTs which have come in IRGN treatment. They say that steroids are actually counterproductive. But in our experience, we find that if we have controlled infection, then a brief course of steroid may actually be helpful. So we find that patients who have received steroids, it's a retrospective study, but we find that if we are controlled infection, a short course of steroid may help these patients. So this is the long-term renal outcome of those with IRGN, with diabetic and without diabetic. As we can see here, those who had diabetes, of course, fared poorly because they have an underlying diabetic kidney disease as well. So any acute rise in creatinine among diabetics with an active infection, rule out IRGN. Early diagnosis is the key. Control of infection leads to better renal and patient outcomes. So this is our experience of 5,400 biopsies, of whom 579 were diabetic kidney diseases. We find that these were the indications. So whenever we are biopsying, we look at what is the indication. So nephrotic syndrome was the most common. AKI with CKD or AKI alone put together is the important indication. Rapid decline in GFR was the indication in 20%. Active urine sediments was about 20%. So absence of diabetic retinopathy was 12%. But the most important is the increasing proteinuria and AKI. We find that NDKD is about 49%, diabetic kidney disease about 31%. We find both in 20% of these patients. These are the various histological findings. Acute, as we saw already, AKI was the common indication. So AAN was the most common finding, followed by IRGN, membranous nephropathy, IgA nephropathy, and FSGS. So we did a multivariate logistic regression to predict NDKD, and those with a duration of diabetes of less than 5 years, those who didn't have end organ complications, those who had oliguria at presentation, and those who had acute rise in creatinine, actually these were the factors that were predicting NDKD better. So this score was validated, and in fact, an app has been developed for easy use at bedside for the identification of NDKD. So this is my last slide on NDKD among diabetes. We find AIN is the most common, and these are the important factors that you have to consider in patients who have a lesser duration, those who do not have end organ damage, those who have oliguria, acute rise in creatinine, and low serum C3 level. So every patient will give us a latent interval. If we miss that latent interval and do not biopsy in time, we actually miss these NDKD. So as they say that a stitch in time saves 9, or needle in time actually saves 9 further needles that you might actually end up putting it in their neck. Thank you very much for your patient listening, and thank you for the opportunity. And I also take this opportunity to thank all my teachers who are here, and also Dr. Vamsidhar, whose data I have presented today. Thank you.
Thank you, Dr. Meyappan, for your very lucid and very fast presentation of such a big topic. If you have got any questions or queries, the audience may ask them. I think it's perfect. So kindly go ahead with the ceremony.
Thank you.
So I have one question. Is a biopsy indicated in all the cases? Is it needed in all cases, or
Biopsy,
because you have shown biopsy in all the cases?
No, sir, not in all cases of diabetic kidney disease. As I was just showing, that the main thing is duration. If it is less than 5 years, if there is no end organ damage like no diabetic retinopathy, if there are active sediments in urine, if the rapidity with which the GFR is falling is very rapid, by rapid I mean that the GFR fall is more than 10 ml per minute per year. So these are the main indications of doing a biopsy. So if any of these is there, a timely biopsy will help pick up these patients, because the treatment can be very life-saving for these patients. Yes, anyone with diabetes and renal dysfunction is told as DKD, but these are red flags which we need to identify so that we can treat
Because
them.
the management will
Management
very much
will
differ.
actually maybe opposite.
Yeah, that's why it's very important, especially in the scenario where diabetes of lesser duration, that if the kidney involvement is there, so should be suspicious for NDKD. Thank you, sir.
Thank you.
We would
Thank you, sir. Now I request President AMA, Dr. J.V. Rai, sir, Organizing Secretary, Dr. Anurag Singh, sir, and Secretary AMA, Dr. Ashutosh Gupta, sir, to kindly honor the speaker and the chairpersons. Thank you.